Good afternoon, ladies and gentlemen. I'm Sean Bello. I'm a cardiothoracic surgical trainee in the Southwest Deanery. Repair of less than severe functional TR remains controversial. This is particularly in the setting of repair of mitral regurgitation, with often moderate functional TR being left unrepaired. I'll present findings from a study we carried out in Papua, which looks at the natural history of this cohort of patients. So just a brief recap, about 90% of cases of tricuspid regurgitation is secondary to pathology on the left side of the heart, described as functional TR, with predominantly just only about 10% being due to primary tricuspid valve disease. And in the pathophysiology of tricuspid regurg, annular dilatation is used to describe the cause of functional TR, and this is often secondary to the increased afterload put onto the RV due to pathology on the left side of the heart, and this is where we sort of focused on. And some actually describe the pathophysiology of functional TR in three phases, and this is sort of to guide management. There is an appreciation that the annular dilatation is a progressive phenomenon, and when the disease process gets to what's called phase 3, there is, in addition to annular dilatation, leaflet tethering. And once the leaflet tethering gets to a particular range, it's advisable to carry out anterior leaflet augmentation in addition to the favored ring annuloplasty. Looking at the magnitude of the problem, the incidence of functional TR in patients undergoing left heart surgery is as high as 30%, with late functional TR being shown to be associated with lower event-free survival at 15 years. And it's well known that redo cardiac surgery for late functional TR carries quite a high mortality. So the current EX guidelines gives a class 1C recommendation that severe functional TR should be repaired during mitral valve surgery. There is a lack of, obviously, robust study. But how we tackle less than severe functional TR in this setting remains controversial. So we sort of looked at the natural history of this group of patients in our study, predominantly focusing on two main endpoints, which was the severity of residual TR at follow-up, but also what their functional status was when we saw them. So we had a record of all patients who had moderate or severe functional TR during mitral valve surgery. Between 2007 and 2010, we reviewed. We used preoperative transthoracic echo to evaluate their degree of functional TR at time, annular diameter, also pulmonary artery pressure, LV and RV function and size. And pre-op functional status was also noted, and at follow-up, we obviously noted their current functional status, and all these patients had a follow-up transthoracic echo. Following the exclusion criteria from the study, we excluded patients who had endocarditis, emergency surgeries, and reoperations, and those that had presence of ventricular pacing wires. So 338 patients had isolated mitral valve surgery over a 4-year study period. 62 of these patients met our study criteria, of which we were able to follow up 54 patients, and they all had a mean logistic Euro score of about 7.6. Now, only 3 patients from our study group showed deterioration in functional TR after a mean follow-up of 2.6 years. I just described that in this table, which essentially illustrates patients' TR status and their New York score at follow-up. So on the left column, we had 49 patients who had moderate TR before the initial operation, and at follow-up, only 3 of these patients had a deterioration in their TR. And in addition to that, you can see their median New York score had improved as well from 2 preoperatively to 1. And of the 5 patients who had severe TR before their mitral valve surgery, the median NIR score for this group of patients also improved from 2 to 1. So essentially, from our study group, the patients appeared to be improving. In addition to that, pulmonary artery pressure, RV function, was also found to either remain the same or get better throughout the study period. So from the study, we sort of drew the conclusion that it appears moderate functional TR improves with time in a majority of patients who undergo mitral valve surgery without concomitant tricuspid annuloplasty. This wasn't what we expected when we initially started, and the findings do not support current guidelines. We recommend, as a result, a prospective randomized controlled trial to sort of evaluate the role of concomitant tricuspid annuloplasty along with mitral valve surgery. And obviously, the study limitations are, as shown here, it is a very small study. It's very difficult to draw any particular conclusions, but as well known, the heterogeneity of the reports that we have and the paucity of data dictates that a more robust study is carried out to aid future management in this group of patients. Thank you.